My name is Dr. Kevin Ewanchyna. I'm the Oregon Medical Association's physician champion in the area of prediabetes and diabetes prevention. I'm a family physician who serves as a Chief Medical Officer for both Samaritan Health Plans and Intercommunity Health Network Coordinated Care Organization. In May of 2018, the Oregon Medical Association presented diabetes prevention workshops at locations throughout the state of Oregon. Today we're presenting the program in video format. Special thanks to the American Medical Association, the National Association of Chronic Disease Directors, and the Centers for Disease Control and Prevention for support of this collaboration. Our objectives today are going to be describing the trends in type 2 diabetes and the implications for clinical practice. Also, we'll review the evidence that supports referring patients with prediabetes to a lifestyle change program. And finally, we'll discuss the key steps that physicians and care teams can take to prevent diabetes. Let's talk a little bit about the epidemiology and the clinical burden of prediabetes. We're going to discuss a case with Frank, and Frank is an example that we all face as healthcare providers when caring for these patients. Frank is an example that will seem very familiar to all of us that are engaged in patient care. He's diagnosed with prediabetes at the age of 55, and Frank's physician does what most of us would do. He or she advises Frank to lose weight, eat healthier, exercise more. And Frank tries his best, but making these lifestyle changes is hard. And so it's not surprising when Frank is diagnosed with type 2 diabetes a few years later. Now, let's review all those things we need to do with Frank at this point, now that he has this diagnosis. First of all, we need to explain what this diagnosis means. And that alone could take the entire 15-minute visit or longer. But we also have a number of other tasks to consider. Do we need to get him a glucometer? And if so, we need to make sure that he can get all the supplies he needs to use it. He needs a referral to diabetes education for diabetes self-management training. He'll likely be started on metformin, and that's more counseling that we need to do. He'll probably be the same for a statin, again, more counseling. And does he need aspirin or an ACE inhibitor if he has hypertension? He'll need regular eye exams, not to mention a number of labs. And we'll need to repeat this routine with Frank about every 3 months for the rest of his life. Despite working to manage his diabetes, Frank eventually develops retinopathy, then chronic kidney disease, and the list of things that we need to do to take care of Frank just keeps getting longer and longer. And finally, unfortunately, Frank has an MI and dies. This is a devastating outcome for Frank and his family. And as physicians and providers, this is extremely demoralizing for us. This is why we need to get ahead of type 2 diabetes before it starts. Now, turning to the epidemiology, this graph represents the prevalence of type 2 diabetes over the past 20 years. And you can see that the prevalence has been steadily increasing. And now we have an estimated 30 million Americans with diabetes. I know we're all very familiar with the negative health consequences associated with diabetes, but sometimes it's helpful to still review some of these statistics as a reminder. People with diabetes are twice as likely to develop hypertension compared to people who don't have diabetes. People with diabetes are 80% more likely to be hospitalized for a heart attack, 50% more likely to be hospitalized for a stroke, and 70% more likely to die from heart disease or stroke. This is a condition associated with substantial morbidity and mortality in our communities to diabetes. 176 billion were due to direct medical costs that we just reviewed, and $69 billion were due to indirect costs such as lost productivity. There are a number of staggering cost statistics related to diabetes, but the one that I find the most compelling is that more than 1 in 5 healthcare dollars is currently spent on diabetes. Given that we have 30 million Americans already having diabetes, how can we stem the tide? What can we do to get in front of the problem? We need to address better the care of the 84 million American adults with prediabetes. That is more than 1 of 3 adults. And recent data from the Centers for Disease Control and Prevention showed that among those 84 million Americans, 90% do not know they have the condition prediabetes. For patients and physicians, this should be a wake-up call. There are 3 standard blood tests for diagnosing prediabetes. And these risk factors for prediabetes mirror those of diabetes: being overweight or obese, increasing age, a family history of type 2 diabetes, racial ethnic minorities, and a sedentary lifestyle. In the diagnosing of prediabetes, we can use the hemoglobin A1C, a fasting plasma glucose, or the oral glucose tolerance test. If left untreated, approximately 15 to 30% of people with prediabetes will progress on to develop type 2 diabetes within 5 years. Now, it is difficult to estimate an average rate of progression because it's highly variable, depending on a number of factors. We already talked about this: race and ethnicity, age, whether the glucose or A1C is at the higher end of the pre-diabetic range. But 15 to 30% progression over a 5-year period is a reasonable statistic in the United States. Over the next 5 years, a typical large practice could experience a 32% increase in the number of patients with diabetes. And this type of increase in the number of patients with a serious medical condition can have a significant impact on the functioning of our practices. Patients with diabetes are among the most cognitively consuming, emotionally consuming, and time-consuming patients. We just have to refer back to that laundry list of things we need to do with diabetic patients every 3 months when they come into our offices. And I know this is not a feeling reserved only for primary care physicians. If you're a surgeon, seeing type 2 diabetes on the problem list means that patients are at more risk of poor healing and complications. If you're a cardiologist, type 2 diabetes on that same problem list is again going to change your thinking and your plan for that patient. So what are the challenges to better managing our population with prediabetes? First, expecting physicians to single-handedly address a health problem that afflicts 84 million people is not realistic. Physicians and care teams are under immense time pressure and clearly do not have the time to deliver an intensive behavioral counseling intervention to 84 million people. We also do not have the ability to address many of the social determinants that influence our patients' health outside the setting of the office. But we can do this as a care team. Next, we're going to talk about the evidence behind a diabetes prevention program. I've painted a picture of doom and gloom about diabetes itself, but I want to pose that there is an evidence-based solution, the diabetes prevention program. And the most significant key take-home point is that prediabetes is a reversible condition. What is the National Diabetes Prevention Program? It's a year-long intensive lifestyle change program where individuals participate in group sessions that take place on more or less weekly basis for the first 6 months of the program, then typically monthly sessions for the second 6 months. These group sessions are led by a trained lifestyle coach, and that coach can be anyone. So they can be a layperson, they can be a licensed healthcare professional, it doesn't matter. And all coaches receive the same specific training, and they're taught to deliver the specific curriculum that is approved by the CDC. The curriculum is truly about comprehensive lifestyle change. Diet, exercise, but also sleep, stress management, and very importantly, strategies to make lasting behavior change. So it's not just knowledge transfer, but participants also develop the skills needed to turn knowledge into actions that result in sustainable lifestyle changes. The goals of the program are for participants to lose 5% of their body weight and to achieve 150 minutes of physical activity per week. There are in-person forms of the DPP available, and some of these are offered by healthcare systems or physician practices. And some of these programs are actually offered by community-based organizations. In fact, the YMCA is the largest provider of in-person DPP nationwide. There are also online or virtual forms of the program available. All modalities focus on empowering individuals to make and maintain lasting lifestyle changes through motivation and problem solving. The National Diabetes Prevention Program is rooted in a large body of evidence, which starts with the original Diabetes Prevention Program study conducted over 15 years ago. The Diabetes Prevention Program clinical trial was a 3-arm randomized control trial that included approximately 3,200 individuals with prediabetes. The participants were randomized to receive either placebo or metformin 850 milligrams twice daily, or to participate in an intensive lifestyle coaching, which is what we now refer to as the DPP. At an average follow-up of 3 years, the intensive lifestyle intervention reduced the incidence of type 2 diabetes by 58% relative to placebo. And it's hard to think of anything in medicine that we do currently that is that effective. In comparison, the metformin reduced the incidence of diabetes by approximately 31% relative to placebo. So the intensive lifestyle intervention was nearly twice as effective as metformin. But the study didn't end after 3 years. In the Diabetes Prevention Program outcome study, there is now 15 years worth of data follow-up stating what we've observed is a lasting impact of the intensive lifestyle intervention, with diabetes incidence still being reduced by 27% at that 15-year mark. While this intervention didn't prevent diabetes in everybody, it also delayed the onset of diabetes in many individuals. And it's estimated that the intervention delays the onset of diabetes by a median of approximately 4 years. Put another way, the original research showed that if you deliver the program to 100 individuals, 3 years out, we would see 15 fewer cases of diabetes. The program has other health benefits. For example, it lowers blood pressure. It also makes participants less likely to need antihypertensive medications and lipid-lowering medications. So there's good value. We now have such extensive evidence for the DPP that it's being incorporated into clinical practice guidelines. And here we see the United States Preventive Services Task Force guidelines, which classify prediabetes screening as a grade B recommendation. Clinicians should also consider screening people with a family history of type 2 diabetes, a past medical history of gestational diabetes or polycystic ovarian syndrome, and racial ethnic minorities. We can consider screening these patients at younger ages and lower BMIs. For example, African Americans, American Indians or Alaskan Natives, Asian Americans, Hispanics or Latinos, or Native Hawaiians or Pacific Islanders. We should consider screening those people earlier than the recommendations. But what's most significant and what you normally don't see in the recommendation box is the USPSTF making a treatment recommendation. They recommend referring patients with abnormal glucose or prediabetes to a lifestyle change program. And the American Diabetes Association also recommends referral to intensive lifestyle change programs. Not only do we have clinical practice guidelines and data that support the diabetes prevention program, we now also have Medicare coming on board. And this is a result of the CMMI, which stands for the Centers for Medicare and Medicaid Innovations, demo project conducted by the YMCA of the United States. And the purpose of this demo was to test the delivery of the diabetes prevention program to senior citizens on Medicare. The demo not only resulted in improved health for all the participants, it also saved CMS money to the tune of $2,650 per participant over the course of 15 months. Because of the success of this demo, in March 2016, CMS announced that it would expand this model to all Medicare beneficiaries. And Medicare coverage for the DPP began in April of 2018. These new set of services will be available to all Medicare beneficiaries with no copay who meet the definition of prediabetes and are verified by a lab result. In addition to covering 6 months of core sessions and 6 months of core maintenance sessions, CMS will also cover an additional year of maintenance sessions, provided the patients meet this 5% weight loss minimum. The Medicare reimbursement is for organizations or health systems that offer a CDC-recognized lifestyle change program. The maximum reimbursement of $670 is for the entire 2 years of that service and for those that meet that minimum weight loss of 5%. In order to be a Medicare supplier of the CDC-recognized Lifestyle Change Program, organizations must have been offering this program for at least a year and achieve preliminary recognition or currently have full recognition from the CDC through its recognition program. Once an organization received preliminary or full recognition, they are then eligible to apply to be an approved Medicare vendor. This application is separate from an approved supplier designation for medical services reimbursements. More information about this can be found at cms.gov, then putting capital M, capital D, capital P, MDPP in the search box. So, treating patients with prediabetes helps clinical practices, helps patients and families, and helps reduce healthcare costs. It's all about the triple aim. And starting in January 2018, under CMS, there are 2 improvement activities that can incentivize physicians to identify their partners with prediabetes and refer them to a diabetes prevention program. So now that I've talked about what needs to be done, let's talk about how to do it with the tools and resources that are available to us. The American Medical Association and the CDC have partnered together to develop tools and resources to help physician practices that want to tackle diabetes prevention in their own population. All of our tools can be found on the website www.preventdiabetesstat.org. Again, that's www.preventdiabetesstat.org. In the next few slides, I'm going to briefly talk about the 5 steps to screen and manage patients with prediabetes. Step 1. How do you create awareness? You can hang educational posters and distribute informational handouts, such as the one we are calling, Are You at Risk for Prediabetes? You can put these in the exam rooms or in the waiting areas. And the AMA has handouts you can download from preventdiabetesstat.org, and these are free for your use. In addition, the AMA has partnered with the CDC, the American Diabetes Association, and the Ad Council to launch the first consumer awareness campaign on prediabetes. All these materials in this campaign, including videos and posters, are available for physicians to use in their practices. Step 2 is identification. We can identify patients with prediabetes by having patients complete a diabetes risk assessment before their visit, by arranging a pre-visit lab test before the planned care appointments, and we can have our medical assistants or nurses do this for us. This approach will allow us to have a face-to-face conversation with the patient about the test results during the visit. We can also utilize our electronic health record to identify patients with prediabetes. We could create a prediabetes registry using a body mass index that equal or greater than 25 or 23 for patients of Asian descent, and a blood glucose or hemoglobin A1C level in the prediabetes range. We want to exclude any patients with existing diagnoses of diabetes, type 1 or type 2. And once we've identified patients with prediabetes through the electronic health record, our practice could reach out to them in a variety of ways, through email, patient portal, phone call. Step 3, the education process. Once we've identified our patients, we want to educate them, and think of this as a brief intervention prior to offering the treatment. With these key points here, your blood sugar is higher than normal, but not at the level of diabetes. And this condition is called prediabetes. Prediabetes is a serious condition. It raises your risk of heart attack and stroke and poses a very high risk of eventually progressing to full-blown diabetes. But prediabetes is reversible and treatable. And the good news is that most patients with prediabetes can avoid or delay developing diabetes by losing weight, becoming more active, and eating more healthfully. Losing 5 to 7% of your body weight is the goal for diabetes prevention, and this would only be about 10 to 14 pounds for somebody who is currently weighing 200 pounds. I cannot stress enough how empowering this is. These are patients that have probably been told their whole adult life to lose weight, thinking 50 to 100 pounds or more. But now we're giving them hope. only 5% weight loss carries great health benefits and could reverse prediabetes. So these messages help motivate patients. And it's important to emphasize that type 2 diabetes is preventable and that it's an opportunity to take action. Step 4 is the referral. We want to refer to an evidence-based diabetes prevention program so that they can take actions to prevent diabetes. If your patient is interested and ready to make healthy lifestyle changes, refer him or her to a CDC-recognized diabetes prevention program. And some patients might want to attend an in-person program, but for others, there are now virtual or online diabetes prevention programs available. You can locate a local diabetes prevention program on the CDC's Diabetes Prevention website, or by going to the preventdiabetesstat.org website. The American Medical Association kit includes sample scripts or letters for notifying patients, especially if creating a list of eligible patients from the electronic medical record. Step 5 is the follow-up. And that final thing on the list of the steps to do to help patients prevent type 2 diabetes is that patient follow-up. You could plan a 3 or 6 month follow-up with your patient to assess their progress towards lifestyle goals and weight loss. And patients really do appreciate the support and the involvement of their physicians in diabetes prevention. So here are just a few tips now for supporting prediabetes screening and treatment. Having a physician champion in their office is very important at the prevention and the establishing of systems that are needed for screening and treating prediabetes. And this is a huge driver for change. Ensuring that everyone is aware of prediabetes, its health risks, and the opportunity to reverse the condition is another important step in the process. And above all, frame that this has a process or a quality improvement lens. We are talking about a clinical practice change, and we saw that the AMA has support for doing all of this work through its CME offerings. And this process needs to be automated to relieve any clinical burdens on us in practice. So I want to highlight some CME opportunities from the American Medical Association. You don't have to be an AMA member, and there is no cost to register. And the first is an online module that takes about 10 minutes to view. And for that, you can earn 0.5 AMA PRA Category 1 credits. This activity is also eligible for CEUs. The AMA has an improvement activity that is eligible for maintenance of certification. And for more information on this activity, contact Janet Williams at the American Medical Association. And her email is at the end of this slide presentation. So now is the time to focus on diabetes prevention. We know it's a growing societal burden of diabetes and prediabetes. We now have an evidence-based diabetes prevention intervention that exists and works. This can align with new payment systems and regulations, and we have an opportunity to strengthen the clinical and community linkages to improve health outcomes. For more information about the AMA resources, janet.williams@ama-association.org. Again, that's janet.williams@ama-assn.org. So join with me to prevent diabetes from occurring in the first place, and we can make a healthier Oregon together. Thank you.